Good afternoon, everyone. Thank you so much for joining us, and I want to welcome you on behalf of Cope Health Solutions to our webinar today. It's going to be focused on financial sustainability post-COVID. The title is Maximizing Revenue from Fee-for-Service and Value-Based Payment Contracts and Other Arrangements. Before we just jump into the webinar, I do want to say on behalf of our firm, all of our leadership and our team, we thought it was very important to share that the events of this past week have absolutely brought into focus for many of us the need for concrete changes to ensure social justice, and just to share that our firm, has been and continues to be committed, both from a mission and action perspective to eliminating disparities and inequities. And so we thought it was important to share that, take a moment to consider that. We know that there's a memorial happening today, and so we didn't want to not address that and let everyone know that that is important to us. And we hope you all are having some time today to reflect on that. We do thank you all for taking the time to join us, despite the fact that you have extremely busy schedules and it is a very stressful time for folks. So without further ado, we will launch into the webinar. So I'd like to introduce our presenters today. Really pleased to have a longtime friend and executive consultant with our firm, Dwayne Donner. And Dwayne ran the largest hospital association in the country, the California Hospital Association, for many years, representing 400 hospitals and health systems, is a leader nationally in understanding where healthcare is going, and has the history and experience to understand what these changes mean to us. And he's been on many boards across the country and also received ACHE's highest honor. We're thrilled to have him on our team and to share with you his expertise today. And likewise, Brent Hardaway, one of our principals. Brent has extensive consulting experience around all aspects of healthcare operations, planning and strategy. Brent's an expert on clinical integration, physician alignment, and works with the firm nationally on both coasts, Hawaii and Texas, to help folks succeed in those areas. And likewise, Carla D'Angelo, who works the same geographies as Brent nationally in Hawaii, across the domestic and U.S. and Hawaii. And she's one of our vice presidents, has real extensive experience, has actually sat on the health plan side of things. So when we talk about how to maximize your relationships with health plans, she's been that health plan finance person sitting on the other side of the negotiating table. A lot of deep experience around provider collaboration, health plan contracting. So very pleased to have this group with us. A little bit of housekeeping. So we ask that during the webinar, if you have any questions, please go ahead and launch them through the Q&A feature or the chat feature. You also can send an email to info@copehealthsolutions.com. So however you want to contact us. What we're going to do is at the end of the PowerPoint, we will have some Q&A if there's time. But even if we don't get to the Q&A, we will document all the questions that have been submitted, and we will send you out a written Q&A along with a PDF of the presentation and a taping of the webinar. And you'll get that within a couple of days. After the presentation, you'll also get a brief survey. We'd really appreciate your feedback on that. So the agenda today, we're going to talk through a high-level overview of the COVID crisis, impact on revenues. We're going to talk about contracting market drivers and considerations, maximizing revenue under your current contracts, and also other funding sources. There still is federal emergency relief money out there. We're going to talk about how to prepare for a successful 2021 and future contracting years, because some of you will be in multi-year contracts, and then we'll go to Q&A. So at a high level, and a lot of other folks, Dwayne and Brent and Carla will cover some of this, but the financial impact is very significant from COVID-19. We all know that, and it's not ending. We can't pretend that just because we're coming out of this a bit, financial impacts are ending. So people continue to have revenue and expense impacts from this, both at an organizational and, of course, a personal level. So what's really important now is providers have to be really strategic. You got to get those tactics and actions moving, but they need to be based on a strategy to really improve access to care, maximize your revenue, reduce costs in the now. But at the same time, you really want to look at what am I doing now that will both maximize short-term revenue, but also I want to set myself up for success in 2021 and beyond. And there are things you can do that are really important, and we're going to talk about those today. And then finally, again, we want to remind folks that after these disasters, people tend to get back to their normal work eventually. And of course, you're focusing on those short-term maximization of revenue, and you're focused on your contracting for 2021. But you don't want to forget that at some point the federal government may release another application process or funding process other than just auto payment for some of the relief money. There's at least $75 billion out there. So just a reminder to keep your eyes on it as well. And with that, I'm going to hand it over to Dwayne.
Thank you, Alan. What are we looking at in today's market? Clearly, we had to change almost overnight and make adjustments that had not been anticipated or budgeted. We started out with shifting utilization patterns, and we know all of the stories about patients avoiding either inpatient care or ambulatory services, the orders to suspend electives as well as other procedures, and to devote our attention to developing surge capacity and preparing ourselves for an expected large increase in utilization of COVID-19 patients. And we saw obviously a shift from a patient acuity by care setting, and that was because with fewer inpatients, those that were remaining had a higher acuity level. The same thing was true for ambulatory patients, either in the hospital outpatient departments, ERs, or in clinics. With that change was the emergence of other new technologies like telehealth. Telehealth's been around for years, but it exploded. And just to give you an example, between March of 2019 and March of 2020, healthcare telemedicine claims in the private industry, private payers, increased by 4,300%, and it's still going up. So we're going to see that, I think, as an ongoing experience. Accelerated regulatory and payment changes. Obviously, federal and state government made changes, expanded reimbursement for telehealth and other services, and created new incentives recently. CMS increased the payment incentive to Medicare Advantage plans by 10% if they would add telemedicine to 8 services, one of which was psychiatric care. Patients changed. They were motivated first and foremost to stay alive, and that meant fearing the disease exposure, particularly if they were vulnerable in some form. And because they were forced or they chose to go to these other areas of delivery, telehealth being an example, they found it to be more convenient and safe than they had originally anticipated before this came about. The evolving information has also helped change a patient's behavior. And now we're seeing, with information saying it's safe, that there is some movement back to the way in which people utilize services, but we're a long ways from where it was when we started. You know, the technology is really great, and for the providers and the patients, but it does have a destabilizing effect on people. The new technology is developing and widening the gap between what we can do and what we can control. And remember that stress is due to 2 things: lack of predictability and lack of control, not over others, but of ourselves and our own environment. As we depend more and more on these external electronic and technological sources, we should keep in mind that there are 3 primary external sources for this: dedicated private clouds, multiple public clouds, and legacy platforms. Using all of these is going to increase cybersecurity risks, and it's important to make sure that we stay on top of that and don't let ourselves become more vulnerable to cyber attacks. Heightened medical staff concerns. This is also true for employees. Obviously, PPE and their safety, their mental health condition, burnout, fatigue, All of those things play a part of these individuals who are healthcare heroes, been giving their lives 24/7 now for several weeks. Hazard pay and appreciation are important. Appreciation actually more important than hazard pay. Disparities in healthcare obviously need to be dealt with. Some of those have been emphasized through this COVID-19 experience, but they existed before, and inequities in inequality, in the inequalities in things like salary and so forth. Right now, today, we have the greatest gap in income inequality in the last 5 decades. And you see that with all of the social unrest, everything's coming together sort of in a perfect storm, and we have to be prepared to handle that, not only as healthcare providers, but as citizens. And then we have to look at unethical entrants. Today, there are more than 250 sellers of COVID-19 tests and masks. And a good number of those tests are not valid. They don't perform. And some of the masks do not meet standards as well. So there is a door opening here for people that want to take advantage illegally, and that requires extra care on our part. And I've already mentioned cyber attacks, which clearly fall into that category. Uncertainty and disruption, I've started to cover this. It's not going to be linear. It will ebb and flow depending on what's happening, not only within healthcare, but also in society. Widespread distribution and misinformation, creation of soft facts and conflicting messages, these are confusing to the public and do not serve us well. Our best way of attacking this is to keep factual, keep clear and crisp in our messaging, and make sure that the messages are on target. We're depending on individual compliance with new patterns related to social distancing, wearing of masks, and also engaging in proper behavior, safety-oriented behavior. It's clear that people have sort of had it, and they are doing things now together and in groups, not just in protest, but social gatherings on the beach and on parties and so forth. And people are not adhering to the policies that have been promoted and adopted to help them keep their health. So it's a real dichotomy. People want to stay healthy, but they're doing things contrary to their own health. There are no penalties per se at this point, but our country is different. There are only half a dozen nations in the world that really have allowed on voluntary compliance to the degree the United States has. And if we get another wave, and we're bound to get hot spots simply because of the way that the people behave, then we have to deal with those in that context of patient care versus reopening the economy and public demands. Our job, of course, everyone, is leadership and creating that trust, taking decisive action that's based on facts with good, clear solutions, and then make sure that we are communicating appropriately. The political environment is adverse in some ways to what we're doing. Everybody, regardless of party, wants to have everybody healthy, prosperous, people of goodwill, and in a peaceful environment. But the polarized electorate that exists today has been caused by the political agendas of individuals and of parties. And when the politics overtake the real underlying social values or the goals that everybody agreed to, we end up with the kind of disruption and polarization that we have today. And it does create unprofessional conduct and certainly a lack of goodwill. And an absence of sufficiently trusted spokespeople. And even when people do talk, most of the listeners are already, they have their mind made up. They either listen to one and discard the other, or vice versa. And that, again, gets to part of the environment in which we're in today. 1 in 4 workers is unemployed, and those are concentrated in travel and hospitality. We know what those are. And that's a different kind of recession or depression than we normally have. And so uniquely, this pandemic has created circumstances which do not exist normally in an economic, normal cycle, economic upturn or downturn. We've had uneven reopening by states, by counties, by cities within counties. And again, those are confusing, but they probably will result in different hotspots being developed from time to time as their priorities change. Social and societal values, we're having to balance our individual self-interest with the mutual collective benefit of society. And right now, we're not bringing those together in a balanced way. I don't know what the next normal is going to be, but I think it's accurate to say we're not going to have just one new or next normal. There are going to be several as we go through this entire process. The role of the media plays a part here as well. And they have a responsibility to ensure that we move in these directions in a way that is not only economically, but also socially acceptable. Next slide, please. Recovery. Alan did refer to this, and recovery is extremely important. It's like flying the airplane, changing an engine, and redesigning the space inside the cabin. When we look at things that we're going to do in reorganizing and optimizing care in the future, we obviously have to engage patients differently with these things that we've talked about, creating windows for protection between employees or among patients in clinics and outpatient departments. Another one that we have to look at is patient flow. Many times patients end up next to each other waiting in the lab or the radiology or in the imaging. And when they do, they're closer than 6 feet together. We have to rethink all of these things because there will be a liability issue when we move forward in the future. We need to have the right equipment, supplies, flexibility for bed conversions, for example, med-surg unit converted to ICU, arrangements for temporary structures, and how then do we actually sustain ourselves in these new models. Without a doubt, smartwatches and smartphones are going to play a much greater role as we move forward in the future. And putting these all together while we're trying to recover economically and at the same time restructure ourselves and build back our network, our patients, and so forth, means that 24/7 is not enough time. And the challenges are substantial in this area. And we sustain ourselves over the long term, obviously, with payers, government, Medicare, Medicaid, and the private sector. When we look at how we provide leadership with payers, we have to go beyond just the third-party payers. Clearly, Medicare and Medicaid are dealt with differently and with different players and representatives for providers. Patients, though, are directly the responsibility of providers, as are these local elected officials. Make sure that they are plugged in along with employers in the community. Leaving anybody out will tend to backfire downstream as you intend to go back either for fundraising or for community support or education or whatever it may be. Behavioral health is both internal and with the community, and making sure that there's adequate coverage with the payers and dealing with things like telehealth. Those are important. As we know, the employees and the medical staffs have been under extreme pressure, so there's going to be behavioral needs there as well as with the general public. As we develop the delivery model options, we should look at, are there things we should be segmenting and strategies for that? Should we be doing more for diagnostic category? When we look at patients, we say, well, we're going to involve them in all of this new technology. Patients fall into three categories. One, they're either really technologically savvy and they use it in every way now, or two, they have some technological expertise, or three, they have little or no, and in many cases, they're not capable of learning. We have to deal with those three population groups differently as we restructure and recreate ourselves in this next environment that we're working in. We're not going to return to the old volume. Now, in past epidemics and disasters, in every case, volumes returned both in terms of numbers and settings within less than a year. But we had nothing like this pandemic. And it is highly unlikely that we will ever return to the exact same volume in the same settings that we had pre the pandemic. Some of them will return, some of them will be gone forever, and some of them, the venues will change. And it's up to us to develop the pilot programs for patients, and then it may be by diagnosis or other categories, and go to the payers and create those reimbursement models so that through piloting, the providers are able to maintain the patient population, expand the network, and continue to provide services that will be beneficial over the long term. Thank you.
This is Brent Hardaway. I am going to talk about maximizing revenue under current contracts and other funding sources. And next slide, please. We're going to start with the slide that illustrates relief fund availability. We won't spend too much time on this slide, but we can't emphasize enough that this is the best and most important component of maximizing financial stability at this time. And that is to take advantage of the grants and the loans that are being made available by federal, state, and local governments. This slide shows the different federal programs, and you'll see that some are still available while others are not, and still others have yet to have dollars allocated. So in addition to what's on this slide, there are state programs and municipal programs and even insurance companies like Blue Cross Blue Shield of Arizona is doing in terms of accelerated payments and prepayment programs for physicians. So as Alan said, as folks get back to some form of normalcy, it is our advice to be ever vigilant in knowing when new allocations are going to be available. And we're also tracking this, and we'll send out updates when we find out about them. Maximizing all lines of business contract revenue. We're going to talk about two different ways to maximize revenue within contracts. First, reimbursement mechanisms under the revenue cycle along all lines of business, be it Medicare, Medicaid, or commercial contracts. All of them have some components that have been tweaked for COVID-19. We want to make sure you're aware of some of those and some of the things that you might be able to do to maximize revenue for the services you're providing. And secondly, on the right side of the page, network development. We'll talk about expanding the continuum of care and, more importantly, expanding access to the continuum of care in order to maximize revenue. So on the left side, from a revenue cycle standpoint on fee-for-service reimbursement, there's really not much that can be done from a Medicare and Medicaid standpoint, but we would suggest that you work together with your advocacy teams to make sure some of the COVID-19 interim rules become permanent, specifically those things around remote monitoring, telehealth, e-visits, the ability of non-physicians to order home health and other services, et cetera. And also, we want to make sure that you're aware of and take advantage of changes in payments and regulations that are available, such as in Medicare Advantage, CMS final rule gave Medicare Advantage plans a 10% bump if they make telehealth available in 8 new specialty areas. So make sure your contracts with MA plans reflect that. In Medicaid, many plans, many states are following Medicare's lead in transforming reimbursement, like in California, where they have mandated expanded telehealth coverage for both, for both Medi-Cal and private payers. Also, CMS has just approved a bunch of waivers and amendments for state Medicaid and CHIP programs that expand coverage options and improved reimbursement for telehealth use. So make sure you keep tabs on your state Medicaid reimbursement changes. On the commercial payer front, payers like Blue Cross Blue Shield of Tennessee have expanded telehealth coverage and have made those changes permanent going forward. Also, the California example that I gave earlier requires similar changes for private payers. Other commercial plans are covering the extra expenses associated with taking care of COVID-19 patients and waiving or covering patient responsibility portions. In terms of value-based payment and other payment arrangements, we're seeing health plans and providers working to amend their value-based care contracts. Some things to think about in protecting your revenues relative to those contracts. First, amend the contracts if the contract allows. And oftentimes there's a clause in contracts that say that a change in law allows renegotiation. And you could argue that the government stay-at-home orders constitute a law change and might allow you to renegotiate contracts. If you are, in fact, able to get those contracts open, you might think about excluding performance data from this period in the year-end reconciliation, or even pausing downside risk for 20 and 2021, perhaps. On the other side of that, when we're talking about upside medical loss ratio contracts or shared savings or shared loss contracts, there's a possibility of significant shared savings losses because of how costly it has been taking care of COVID-19 patients. That said, though, a recent interim rule from CMS is taking out the costs of COVID-19 related treatments for Medicare ACOs when they're calculating performance. So a couple of other things about that interim rule that I think are interesting. One, it also allows for telehealth visits, virtual check-ins, e-visits to count towards beneficiary assignment in the attribution methodology. This is incredibly important because you could lose significant attribution if only face-to-face visits are counted. So this is a strategy for Medicare ACOs, but not only Medicare ACOs. Any commercial ACOs and shared savings contracts you are in, you should be working on, again, if possible, renegotiating those components. On the other side of the coin, though, of course, there has been, as Dwayne mentioned, a significant decrease in costs associated with fewer outpatient services and elective surgeries. For instance, the 42% decrease in emergency department visits. So your shared savings contracts could be potentially generating a windfall. And also, please note that CMS just put a cap on the next gen ACO gross savings upside at 5%. So the difficulty with counting on that windfall is that there is most likely a lot of pent up demand, and not only pent-up demand, but pent-up demand from clinically vulnerable beneficiaries. So it becomes imperative that we utilize virtual care management services, virtual monitoring, telehealth services to continue to care for those vulnerable populations, and we'll discuss that more in a moment. Hierarchical condition category HCC cannot stress enough the importance of accurate coding during this time, and that has all been complicated by a new set of CPT codes, new set of ICD codes, new HCPCS codes, all created to capture COVID-19 testing and care, and telehealth and virtual visits. And Carl is going to talk a little bit more about the importance of accurate coding on the VBP quality programs. Retail pricing strategy from a short-term perspective, because systems have lost revenue from all services, but especially from high-margin complex services, you should consider, again, if you're able to open negotiations with payers, higher margins on high-volume services. That being said, though, if you take a long-term view of this, it may make sense because health systems typically make 120% of their margin on commercial outpatient diagnostics and procedures. You may want to think about new pricing strategies that more highly values the higher complexity cases that can only be done at tertiary and quaternary facilities, enables more competitive pricing on commodity type services that are being provided by many, many providers. Initiating discussions on post-COVID payments and negotiation of extensions. CMS is discussing making permanent the temporary telehealth reimbursement provisions. We would suggest doing the same with commercial payers. And because there will continue to be these extra costs in treating COVID-19 patients, now's the time to codify those reimbursement changes, not just for the short term, but for the long term. Moving over to the network development optimization, there are a number of things that can and should be done right now to maximize revenues. In this section, we're talking about expanding the continuum of care, more importantly, expanding access to the continuum of care, and using this time to generate greater alignment, not only with the providers in the community, but with the people you serve. So how do you do that? Physician and hospital clinical integration. Some of you may have heard one of our previous webinars on supporting physicians through clinical integration. What we're suggesting is this. CMS and the federal antitrust enforcement agencies have relaxed some regulations and streamlined oversight to encourage clinical collaboration between hospitals, health systems, and medical groups in order to treat COVID-19 patients. You're now, as a result, able to build networks more quickly, and as a health system, support practices and even potentially other undercapitalized hospitals to provide COVID-19 services, which is a pretty broad swath of services. That support can range from cash infusions to assistance with expenses to providing telemedicine equipment to accessing better managed care contracts, among other things. So we'd suggest the development of a significant value proposition that allows for the expansion of or development of clinically integrated networks to generate a larger footprint of providers in your market and the potential for improved access. Closing care gaps. We've discussed the issue with the fact that people are not getting access, or people are not accessing care right now. So how do we make sure patients are getting the care they need, preventive care and screenings and so forth? Be very strategic about this. Your data is incredibly important in this. Risk stratification, cohorting of patients to determine work lists for outreach, using the data to understand social determinants that then will help us develop target lists and outreach to those that need transportation assistance, for example. Developing an FQHC strategy, as we've said before, and Dwayne talked about this, 27 million people in the United States will lose their employer-sponsored health insurance. Many of those are going to be eligible for Medicaid. Many more or more will be eligible for exchange marketplace subsidies. If you have some aligned clinics that have a large Medicaid population, potential for a revenue increase for moving it to an FQHC or an FQHC lookalike. In addition, as an alternative, you can think about aligning more closely with existing FQHCs through your CIN or IPA or your network. Optimizing telehealth and e-visits. This is a strategy that has both short-term and long-term benefits. Use telehealth and e-visits to begin the process of closing care gaps and actually triaging those that need further follow-up. It helps with risk scoring, it helps with attribution, it helps with closing care gaps. So let your community and patients know that this is available and is a viable alternative to in-person visits. That's a way to then also, the next bullet, grow panels, using the strategy like we outlined with the CIN, increasing the size of your network, and allowing you to use outreach to close care gaps. All of these things can work towards growing your panels. And then reducing leakage, a scenario that exists that says a competitor reopens first and takes your share of the backlog, and we have to be careful with balancing between opening quickly enough to save or gain market share and putting safety at risk. All of those things are things that health systems are grappling with. One answer to this is to make sure your definition of site of service includes virtual, home-based, and freestanding options. Make sure your care coordination systems and information systems are working well. Make sure your system is easy to use, and make sure if you have developed an access center during the pandemic, use this as a mechanism to manage referrals and increase access to your network of providers. I mentioned telehealth, and virtual and digital health. This is important to add these capabilities to your continuum of care. Knowing that a 99213 E&M code can't generate nearly the revenue that elective surgeries can, this can help close care gaps, generate alignment with community, and the way to generate alignment with physicians. Going on down to restoration of elective and outpatient clinical services. As many hospitals resume elective procedures, we're seeing positive signs of recovery for outpatient visit volume. However, recovery for emergency department and inpatient services lagging. So that indicates that patients are deferring necessary care. So what we're seeing in some of our clients is very strategic, programmatic reopening schedule that takes into consideration not only high volume, high revenue services, but also services that are needed by the most vulnerable. Waivers, exemptions, and reporting. A couple of examples. CMS is temporarily waiving or modifying certain requirements to relieve the administrative burdens and provide additional access to capacities, like waiving 3-day prior hospitalization rule for coverage of skilled nursing facilities. Reconnecting with the community. We're seeing a lot of excellent work being done by providers in terms of digital newsletters, websites, press releases. That has to continue. Additional sources of funding over on the right-hand side, emergency funds we've talked about. We're also seeing a big increase in grants and donations from individuals, from foundations, and from businesses. So that is not an area that folks should be trepidatious about moving into asking for money during a time of crisis. So that's maximizing revenue in, 16 minutes. And so I'm going to turn it over to Carla now to discuss preparing for what's next. Carla?
Thank you, Brent. Okay, so Brent and Dwayne covered a lot of really important points that I'm going to dig a little deeper in and wanted to share with you all as you're thinking more tactically about things that you can do and what you should be looking at. We talked about telehealth and technology, and what Brent shared was ensuring that your contracts, or at least talking with your payers about ensuring that your contracts cover telehealth services beyond the period of time in which the government is continuing to allow for payments of this. And we'll talk a little bit more about that in a bit. But if you are an organization that has invested in telehealth services, which you likely are, make sure that you're thinking about putting in place the proper processes so that you can control for any potential fraud, waste, or abuse situations related to telehealth services. Since this is very new for many folks, some of you have been doing this for a very long time, but those that are a little bit newer into it, just know that health plan contracts do still continue to have audit provisions in there to make sure that visits were medically necessary. And it is very likely that managed care organizations will be coming back at a later date to ensure that telehealth services and providers were doing so within the appropriate guidelines for them, so that there aren't too many visits in one day, or anything that's triggering it. So just ensure that your group has the proper measures and controls in place should that be something that you're investing your time in. Something that Dwayne talked a little bit about, the innovative pilot programs that are going to come out of here. And he talked about how traditionally care has been provided at the convenience of the doctor and the provider. Well, if this pandemic has shown us anything, it's shown that these services are now needing to be centered around the patient, more user-friendly, less time-consuming, more efficient. So when thinking about some of these pilots, we need to understand how to bring things to the patient in a safe and comfortable environment. Brent talked about some of the FQHC partnerships and some of the CBOs, and thinking about high-risk patients. So for diabetics, what can be done safely in the home, COPD, you'll start to see MCOs looking at very targeted populations at the highest risk to see how they can be innovative around different ways to monitor with remote patient monitoring, having medical equipment in the home that can send direct feeds into the electronic medical record. You'll see some examples of this in different wearables and injectables. A lot of the technologies that we've all been hearing about and that Dwayne mentioned, things that we've been hearing about for years, will now be necessitated to be put into use a lot faster than they would have been if this pandemic didn't exist, and certainly if there is another surge. So you can expect to see some more of that, and think about that from your organization's perspective, how you can be helpful in that and participate in any of these kinds of pilots as they come through. And making sure, of course, that you have proper policies and procedures in place when launching or piloting any of these things for audit purposes. When we start to talk about, I'll go down to utilization fluctuations for just a moment. When we think about accommodating the changes of utilization shifts that Dwayne discussed earlier on, managed care organizations are going to be looking closer at site of care opportunities to better accommodate patients. So an example of this will be looking at infusions. I'll just use Remicade for an example. Looking again at moving some of these to in-home infusion opportunities versus clinics and hospital outpatient centers, so to be more patient-centered. However, that does have impact to a provider's bottom line if you do rely on revenue from that in the physician office or in a hospital outpatient center. So making sure that you're modeling that, you understand it, and leverage value-based payment arrangements and capitation for those circumstances where some of those site of care areas may be shifted over. And when thinking about, I'll talk a little bit more in a later slide on some of the payment terms and flexible provisions, but I'll just touch on here right now some questions to ask yourself. If you are in a risk-based arrangement now, how are you optimizing them, and what conversations are you having with your health plan? If you are in a fee-for-service, or if you're in a lower level of risk agreement, can you take on more? Is this something you have the appetite for? Do your contracts have the flexibility to accommodate another surge? Some of the provisions that Brent was talking about that allows you to open that contract for reconsideration, do you have the right provisions in there that can help you both from a revenue perspective, but also from an operational perspective if this were to happen again? And taking time for your organization to do an after-action report or some kind of lessons learned and understanding what your pain points were from this experience, things that you wish you could have planned for better in your contracts, things you wish you could have partnered better with your managed care plans or your patients, and really taking the time to do that will help you identify future opportunities. Okay, so quality. We've been hearing a lot about quality. We talked a lot about quality, and that's for good reason. Quality is a significant portion of the revenue. It's a very important component and key pinnacle of value-based payment arrangements, and as well as your ratings and your perception and reputation in the community. So things that can be done today that will help you prepare for next year are going to help you maximize revenue for the coming years in all lines of business. So we hear a lot about Medicare and Medicaid, but this also pertains to your commercial contracts and private payer arrangements that you have. If you haven't focused on a lot of this recently, now is the time to focus on patient stickiness to your organization. So obviously it will help you with out-of-network leakage and bring in more volume to your business, but it's also going to help you better close some of the quality of care gaps. So what we want you to do is really be focused, hyper-focused on this, even if you are in a Medicare ACO arrangement, MSSP, or something that's paused some of the quality reporting and measurement. You're still going to have dollars around it and associated with it. There's still budgets set for this. You're going to set yourself up for future arrangements and future budgets and incentive programs. So still continuing and reminding your organization to have and embrace a culture of quality and really continuing those efforts, even though reporting is not happening, will only help you in the future. We really want to make sure that that's a hyper focus for your organizations. Something that you can do with improving access to services, which we've talked about, our telehealth and some of the other e-visits, but also thinking about ways if you have mammogram vans or other things that you can bring services to the patient. If you thought about investing in one or something like that, now is the time to go to your foundations. If you're a health system, now is the time to start thinking about and preparing for how to be making this a more user-friendly and patient-centered environment. And we all know, and we were talking earlier with Brent and Dwayne about the comfort levels of our patients and our providers, and we know that physicians and burnout is very likely or could happen as a result of this frontline hazard pay condition environment that people are operating in, some of the experiences patients are having or the anxieties around this. We want to ensure that patients feel safe and comfortable, and that providers, including your office staff, feel safe and comfortable will also help you close care gaps, because we know a lot of times care gaps, meaning, and I'm speaking about HEDIS or QAF or QAR or CAPS, any of those that you're involved in, do have to do with making a visit, and your office staff have a lot to do with that as well. So sometimes we focus so much on the practitioner that we forget about all of our clerical staff and those that are really making the calls and helping drive a patient from getting in and feeling comfortable. How they are greeted at the front office or on the phone is really important. So making sure that you're asking the questions, how your patients are feeling on the phone right when the office staff are there. Documenting patient preferences for things is important as you're taking information on appointments, if they prefer e-visits, if they are comfortable to come in the office. Making sure that you're documenting this will only help your office staff and your patient population feel comfortable, and therefore will help you on the quality side. I did want to point out that health risk assessments are still really critical and really important. You're going to see managed care plans struggling or really thinking about how they can make sure that health risk assessments are done when traditionally they've been completed with an RN or in a home setting. So how can you be helpful on the provider side to work with your managed care organizations to collect some of the information on a health risk assessment, or large employer groups? If you have key employers or large companies near your office and provide primary care services, how can you partner with them to do drives that help people come in for their health risk assessments to document all of the information that will go into risk adjustment and quality? And then, of course, thinking about preparing for next year, and why I'm trying to hone in on quality so much is a risk adjustment is critical. So from a federal side standpoint, even if CMS does provide relief for the 2020 dates of service, which they have come out and said they will, the reality is that some number of patients are simply going to decide not to return to the office unless their health conditions deteriorate significantly. Alternatively, though, this means providers will need to identify these members, understand their risks, have alternative plans in place to treat their chronic conditions, so that this data can be tracked and submitted to your MCOs, to CMS, depending on what kind of arrangement it might be. If you're in a state pilot, it could go to one of your Medicaid, it could go and be submitted to Medicaid. If you're in a Medicaid 1115 waiver state and you're part of a district or a prime or one of the demonstration pilots, programs. All of this information is getting collected and will be used for future pricing. If your organization hasn't done so already, and if your managed care organization hasn't come out explicitly and said to you that the performance data from the crisis period that we're all experiencing right now has been disregarded or will be paused, now is a good time, as Brent was sharing, to really have that conversation and understand what they're planning to do to help in the short term. So we're going to talk about some of the structures of the contracts, and I want to get a little bit more hands-on here. And the next slide has some really good information to share with you. So I'll go through this as quickly as I can. I'm thinking that we know that fee-for-service, in some cases, we've got a variety of providers on this phone, and we've got people who've been in risk for years, since the 80s and 90s, and we have some of you who have just started to dip your toes in and really make your bread and butter off of fee-for-service models, and that's okay, and both have opportunities here that I'll cover. What we know about fee-for-service is there's a lack of innovation, and it does not cover you in times of crisis like this pandemic. So what is your pricing strategy? How are you focusing on enhancing your margin, as Brent mentioned, on ambulatory and outpatient care services in the short term? If you're in risk arrangements, are you proactively evaluating the financial impacts of services with lower levels of care caused by COVID? Have you asked your health plan if you can cap or reduce shared losses through risk corridors? If you haven't already, start these conversations now, because you will end up in a reconciliation period at the end of the year which may not be advantageous to you. So thinking about ways to cap and share those losses is important, and we're seeing that with some of our clients as we're working through these challenges. Really quickly, I wanted to talk about leveraging the lower level of risk arrangement, or leveraging risk arrangements rather, so that you can use some of your PMPM dollars and investments that you have to focus on non-medical areas. So you can use those dollars in your own way to look at how to bring patients in to cover some of the non-medical social determinants. What can you do now? Be proactive. Ask for extensions of things in your contracts today with MCOs, like appeals and grievances, or reconciliations, claim submissions. Be proactive and ask for those extensions, even though your contract states it. Get that in writing. Document all of your conversations and emails with them for your own good, for audit purposes, and for future negotiations. Submit a notice to renegotiate if the contract is not up for renewal. You can do that within even without cause. You can do that within the terms and conditions of your contract. So do that with 60, 90 days, whatever notice is in there. So it'll at least allow you guys to have the negotiations and start some of these conversations. If you're in a risk arrangement, moving on to talking about value-based payment here, if less services are used, right, the health plan would get to keep those savings. So if providers now go at risk, you will too be able to share in those savings generated, and they'll help you preserve the revenue in the future and protects you from revenue if another surge were to come in. Now, there may be opportunities. I was speaking in preparation for this webinar, speaking with a former colleague at a health plan and asked what they're doing around this. And they said for those providers that are in fee-for-service contracts today, and this is on the primary care side, they're looking to do an off-cycle capitation movement to help them jumpstart move into value-based payment, but also to get them into a new contract that they've been talking about and negotiating for several years. So this has really been an impetus to make that move quickly. Very briefly, looking at another opportunity that I was speaking with one of our clients about this week, ask MCOs if they are offering grants for COVID-related expenses or other things. You can use it to purchase PPE, you can use it to reward your frontline staff, but I wanted to share that with you because as you're seeing and what we've seen publicly with our for-profit plans like United and our not-for-profit plans like many of the Blues, they're posting better than expected profits in the first quarter and likely the second quarter, and they're tracking to do well this year. So if you're a not-for-profit health plan like many of the Blues are, they're capped at the margin they can make, and they will need to find ways to invest those dollars back into medical expense or share those rebates back with employer groups. So proactively ask if they can offer a grant to help you and figure out and determine a strategy on how your organization wants to use that. As we're running out of time here, we'll close with another thought on the Medicaid contract terms. If you do have a Medicaid contract for managed care, is to look at what the state is doing right now, and if your contracts don't allow you unilateral opportunity to follow exactly what the state is doing, because we know that you're free to negotiate with a private payer consider those terms, if they're positive or advantageous to your organization. Consider bringing that to your payer to see if you can have that reflected in your experience as well. I'm speaking with a plan this week as well. They were opening contracts and having the conversations with their provider network to be able to reinstate some things that were going to be helpful, such as utilizing state-directed payments to require managed care plans to temporarily enhance the provider payments under their contracts, and that would allow you some additional revenue. So with that, I believe we're at time, and I will turn it to Alan for closing.
Thank you so much, Carla and Brent and Dwayne. I know we have a minute left, so the recap. At the end of the day, it's a different market. At the same time, there are obviously things that continue, like needing to generate revenue. So it's really critical to adapt to those changing patient expectations and think about how you're going to bring people back in safely, while at the same time making telehealth available and getting paid for it. Looking at your coding and your other opportunities to make sure you get paid. Monitoring and really acting on those regulatory changes and leveraging them to the extent you can to build the right network to grow market share. Preparing for future emergencies, of course, thinking about your surge capacity, making sure that you don't forget about this so that in the wintertime it's a surprise. And of course, keeping your eye on that federal relief money. And then at the same time, there's future revenue. So as you work with your health plans to grow revenue, the key is, remember, their revenue is based on membership, risk scores, and quality scores. You help them get those things up, they can help you make more money. So don't forget to work on those. Thank you all very much for attending, and we wish you all the very best for safety. And we're going to sign off. CoPayor Solutions. Thank you.